Welcome. I am Dr. Patrice Berry. Super glad to be able to be here a little earlier than normal. And I'm going to try to find a consistent streaming schedule. My schedule is a bit all over the place. So that's why I do it when I can. Hello to Karen. Hello to the cat lady. And I just want to give a warning. So, the Take Care of Maya case is currently happening. There are people that avoid this case for a variety of reasons. And so, what I'm going to do is I'm going to hold all of my Maya questions until the end. So, if you have questions about the case from a psychological perspective, please let me know. I'm going to cover that at the end. I wanted to first start off with talking about the psychology of pain, and then we're going to look into like how things work with pain, and then what are some effective treatments of pain. And here, because I think all therapists should be trained on this, but not every therapist is. So there are therapists that don't know how to treat chronic pain, and they could say and do things that cause additional problems for their clients. So I've had people referred to me, and these individuals, they were experiencing medical gaslighting, where the medical system, they couldn't figure out what was going on with this individual, and so they immediately were like, it must be a psychological problem. And but they had a neural, like, they looked at all those things, and really what was happening is there was a rare medical condition, CRPS, and a lot of other diagnoses, a lot of other conditions. Sometimes people can look at, oh, is this all in the person's head, which is very, like, because pain is real, even psychogenic pain. So pain is real. And I think all therapists should get this training. If I did have chronic pain and I was looking for a therapist, I would ask them, what is your approach with clients with chronic pain? One of the things that I do is trying to help clients live well with pain. I want to validate their experience. I want to help them increase any functioning that they have, if there are any psychological barriers. So with pain, it's normal that there's depression or anxiety or other psychological effects that come with that. Also physiological, so also like stress can cause physical symptoms can increase emotional symptoms, and they can have this really just complex relationship. And having someone that will sit down and listen, and then also sometimes people being able to admit that they're not completely sure. I wish more doctors would kind of say, "Hey, I don't know." So there's a witness who's on the stand right now. There's a doctor from today from the trial. He did make a point that I will talk about because it was interesting, about redheads in pain, which I had never ever heard of, but I Googled it, and that part of his testimony was correct. Some of the other things came off incredibly invalidating, and we're not going to go into that right now. But yes. So, the nature of pain. So, pain is a very common problem that people will go to a physician to talk about, but it's not always that straightforward. And pain can serve a really important purpose. So, there is a medical condition where an individual can't experience pain, and they're at a higher risk for injuring themselves because they could have their hand on a hot stove and not even notice it. Where then chronic pain can then cause just all types of, it can really impact the person's functioning because it's so complex, where a person is having a lot of physical symptoms. So pain has biological, psychological, and emotional factors that can all just work together, and that can make things more difficult. Chronic pain can cause feelings like anger, hopelessness, sadness, and anxiety. And to treat pain correctly, you first address the physical. That's my, like, you first have to look at the physical, you have to take a look at the emotional and psychological aspects. And there are a lot of different options for treating pain. But when people come to a psychologist or to a mental health professional to talk about their chronic pain, they're often looking for ways to cope with the thoughts, feelings, and behaviors that can accompany chronic pain. And I have a link to this article down below, but the fact of being able to first talk about how looking at progress and improving, that's often the goal. So we want to look at people having progress, but there are times that people have um, degenerative medical conditions. And I've sometimes worked with people on grieving the amount of functioning that they had before if they were never going to be able to function at their pre-injury level, because sometimes that happens where somebody has a certain medical diagnosis that impacts their physical functioning, and now they're not able to do the things that they used to do, which understandably increases feelings of sadness, and the person and we work through that grief. I'm going to talk a little bit later about cognitive behavior therapy, what it is, why. I'm not The way that it's described, I don't do it that way. I tend to add validation, mindfulness. I tend to add other things to it and modify it so that it is trauma informed and that it is also more effective for individuals. Okay? Looking at stress and chronic pain. So, when our body goes into a stress mode, that fight, flight, freeze, or people please, or anytime we're stressed, under stressed, pain can increase stress. Maybe a person is losing time at work or they're not able to work, and there are financial considerations. There are things that are coming up for them that those the physiological reaction of stress can increase pain. It can increase a variety of things. I'm not a medical doctor, so I won't go into that part. I do want to play a clip from a video that I think did a really good job explaining that portion, and it also briefly explains CRPS. I do believe I have it cut where we hopefully won't hear anything triggering. Apologies early if I didn't. I believe I clipped it correctly, but yes. And so here are some tips at the end of that article about how to cope with chronic pain. And that sometimes exercise for some people I work with, we do like it is if they have access to a pool or if they have access just on their bed, it's doing very low impact things if they're able to. I'm also going to talk about spoon theory because I think that can play, and I think all therapists should definitely have an understanding of it because sometimes using language that clients are using, I think that can really help in helping support people that have chronic pain. Oh, hey, AKA the cat lady, anytime. And really, because this was probably a good place to talk about medical gaslighting. Because what can happen? A lot of the chronic pain clients I work with, when a doctor asks them to rate their pain, they often rate it lower than they're actually experiencing it so that they can be heard. People will tell me that they normally say 7 or 8, even though it might be a 9 or a 10, because that doctor has in their mind what a 9 or a 10 should look like. And that came up in some things where people were expecting, okay, a 9 or a 10, you should be curled up in a fetal position, or that a 9 or a 10, this is what I would expect it to look like, which really invalidates the individual because so it is their body. And it's remember, I have a client-centered perspective, so my goal is to always support my clients and to let them know that they can if they tell me their pain's at a 10, I believe it's at a 10. That it's not my job to say, "Oh, well, wait a minute. Could it really be?" And sometimes there are doctors that will do and say things, and that sometimes I saw an article recently of an individual that also experienced some fat phobia as well, where they had a lot of chronic pain and they weren't heard because of their weight. The doctors just kept focusing on their weight and not looking deeper into what was going on with them. And so the individual ended up losing some weight. And then they finally took the time to look deeper. And to me, you shouldn't have to do that in order to get appropriate medical care. So, as a provider, I try to help my clients, if we can, find providers or find people, find situations where they can advocate for themselves. Some doctors hate that. And if you try to advocate for yourself, there are some doctors that will bring up all kinds of stuff. I also try to warn against not talking about Google or TikTok like that. I don't know why that triggers doctors so much. And just so y'all know, the reason why it doesn't trigger me, I love it when clients send me a TikTok that really resonated with them for the week. If they send me something that they learned or some concept that they saw online that they really identified with, I appreciate when they send me those materials because it really helps me see into their world. It helps me know a little bit more of what's going on. So I always believe that the patient or the client that they are the expert in them. So it's not my place to tell them what is or is not going on in their body. It's my job to help and support. And it's a problem with our medical system because our medical system looks at symptoms and then starts like whacking at different problems. And please, if you are keeping track with the Maya case, please take care of yourself because the defense side is testifying is I'm sorry is yeah giving testimony right now, and a lot of it comes across extremely just invalidating and just ooh it in my opinion it can, but I think it could hurt some of the witnesses' credibility with the jury because that jury is definitely paying attention. And so, all right, I want to share this one here. So let's share this tab. So this is on true crime recaps. And they did a phenomenal recap of the Maya Kowalski trial. If you haven't heard of it, so they're just this is only the portion where they're talking about pain. So that's only the portion that I'm going to play. Let me share this.
That's when one of Beata's patients mentioned a rare condition called complex regional pain syndrome, or CRPS. They referred Beata to a local anesthesiologist named Anthony Kirkpatrick. He ran a clinic in Tampa that studied CRPS. One might call him an expert in the field. CRPS is a rare and misunderstood disorder. According to the Cleveland Clinic, it's a neurological condition that causes pain and other symptoms in your extremities, most commonly your hands. It can also affect your arms, feet, and legs. Experts say CRPS is a dysfunction of your central and peripheral nervous systems. It typically develops after an injury, surgery, stroke, or heart attack. The pain itself is often disproportionate to the severity of the initial injury. To understand it a little better, let's quickly talk about how your nervous system works. Your central nervous system is your brain and spinal cord. Your peripheral nervous system sends messages from your central system to your organs and extremities. Let's say you fall and break your arm. Pain receptors near the injury send messages to your brain. Your brain says, "Yep, that hurts," and sends signals back. Those signals trigger an inflammatory response to begin the healing process. Your blood vessels expand so blood cells can reach the injured area. That's why it swells and turns red. As your wound heals, the swelling and inflammation go down. With CRPS, your body overreacts to pain and sends signals your brain can't turn off. So even after your arm heals, you still feel excruciating pain. X-rays say you're fine. CT scans can't see anything. In fact, there is no diagnostic test for CRPS. Doctors can only rely on the patient's word and past medical history. And you can see where this is going, right? It's way too easy for doctors to believe the patient is faking it. When it comes to children with CRPS, the term Munchausen syndrome by proxy enters the conversation, along with the term medical abuse. That's when a
My mic. I did a whole video talking about Munchausen by proxy and covering ketamine and addiction and some other things. And I have that one linked down below. I just wanted to highlight the fact of that sometimes the pain center, it can get turned on, and that patient is truly experiencing pain, and that there are therapies, there are things that are helpful to help the client during their rehab process, to help them uh, really effectively manage and kind of cope with the amount of pain that they're in. And that's where I want to go into talking first about cognitive behavior therapy. Let me know if you all have questions about the psychology of pain, different treatments. And then, like I said, at the end, we're going to talk about Maya's case specifically. All right, there we go. All right. So, cognitive behavior therapy, or CBT, is one of probably the most researched, like it is. Oh, it is a very so I learned how to do it back in graduate school. It is something that has been around for a very long time. For me, it was created by um it was created by kind of affluent people. So it was studied a lot on college students, and it can be effective across a lot of different situations. I tried cognitive behavior therapy. I didn't like it. Okay. So that's my bias. So I am not a fan of CBT because it has you identify your irrational thoughts, and then you identify all the ways that that thought isn't true, and then you try to come up with a more balanced thought. Or there are a few other techniques, there are other things that you can do with CBT, and for me it comes across as invalidating. So if I'm talking with my therapist about experiences that I'm having, good, and so I'm glad. So it really can be effective, and people can have good experiences with it. All right. And it is a really common type of therapy. If you're looking for a therapist that does CBT, you're most likely going to find it because a lot of therapists are trained in it. I'm going to talk later about ACT and so acceptance and commitment therapy and dialectical behavior therapy. And and so there are concepts that I use, I modify it. So what I do is I add mindfulness, I add validation. For me, that helps. So I work with a lot of low income. I work with a lot of people that are racially marginalized, or that are part of the LGBTQIA plus community. And there are valid reasons for that irrational thought, and ignoring that underlying reason can sometimes cause, like, it can not feel great talking about it. And so that's why I like a few of these other techniques more than cognitive behavior therapy. But it takes a look at the connection between your thoughts, your emotions, and your behavior. And with chronic pain, the goal is that a person can learn different skills, that they can learn to kind of better manage the thoughts that they have when they are experiencing pain. Oh, and so it's frequently used for depression, anxiety, all types, pretty much like everything you can possibly think of. Cognitive behavior therapy could be effective for it. Okay. And they go into talking about how CBT works and the risk and benefits. And so, one potential risk of CBT is that you really identify what some of those negative thoughts are, and the thoughts that can go along with that, that might say that that thought is true. And this is the more traditional way to do CBT. There are lots of different ways to do it. And sometimes people can feel worse during that process. And that sometimes it can be upsetting to talk about those things. And but the goal is to learn new skills and ways to manage those negative symptoms. All right. So now let's talk about chronic pain and acceptance and commitment therapy. So this is one that I'm a fan of. And a friend of mine who does have, she's a psychologist, she has chronic pain, and ACT has been really helpful for her. She's actually the one that I first heard about this, and really just getting to look at it more. I found that it was helpful for some of the people that I work with. And it uses components of CBT, and it also and the ultimate goal is to look at the client's values and help them live well with pain. And sometimes there can be some misconceptions about ACT, and and they're trying to look at the goal between pain and suffering. That pain is going to happen, and that with suffering, that I can potentially, the perception of the pain, and not to say that it's understandable and okay that I feel that way, holding on to, let's say, the grief. Because if I'm grieving previous functioning and I'm holding on tightly to that previous functioning, which is causing me more suffering, that possibly a part of my healing might be finding ways to accept. So acceptance isn't approval. Acceptance is just not fighting reality. And that comes from some Buddhist traditions. It's rooted in some of those philosophies. Also, I sometimes look into the Stoic philosophies as well, where you just look at, like, it just is. The pain is, and that the goal is to try to live well with it. So that maybe today, if I'm only able to do this, that I'm not going to blame and shame myself because I wasn't able to be as productive, or that I wasn't able to do all the things that I thought I should have done. And it's being able to say, okay, I have some limitations, and then also I have some things that I can still do really well. And I'm gonna focus on what I can do, and I'm gonna grieve those things um that I've that I'm losing, or that I'm not able to really hold on to anymore. And so the goal of it is accepting experiences instead of rejecting them simply because they may cause chronic pain, choosing behaviors mindfully versus allowing automatic or conditioned responses, and then taking action and having agency in your life rather than becoming paralyzed by unpleasant thoughts, memories, or sensations. And this is a skill based treatment where you learn how to do this. It's not just oh, do these things. That the goal is to help the individual slowly and safely be able to re-engage in the activities that they can do, because often with chronic pain, there can be fear, anxiety, and avoidance behaviors. And avoidance makes that anxiety goes away, but for the moment, but it makes that anxiety and that connection stronger. So, and there might be a modification that I can do and still enjoy that activity. So, on a high pain day, if I have a dog, I might only be able to walk for a minute, when maybe on a good day, I might walk the dog for 10 or 15 minutes. And so it's being able to make those adjustments. Um, and then but on a good day, because sometimes there can be that fear of, if I walk for 10 minutes, I'm gonna have a bad day. And so it's trying to find safe ways to approach the things that 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 cause some of that. And let me come back to the comments to see. Oh, good, good. Cool. So that guilt of not being able to do some things, and for some people it turns into shame. The shame of, like, I'm not a good enough wife, or I'm not a good enough partner, or I'm not a good enough father, or because it can really turn in, because people sometimes have to re-identify and take a look at how they're feeling about themselves. And I think with this, they can find a way to live well with pain. And as they're looking at managing it, because reducing the stress will often help. And let me see. Let's take a look at this one. So, dialectical behavior therapy is another type of treatment. So, I have more training in DBT skills training. So, I have taken, wow, probably about 10 to maybe almost 20 hours of DBT trainings. I haven't done the full certification because so I don't say I do DBT. If they're appropriate for DBT skills training, I will tell them like, "Hey, like this is a part of a program, but we're not doing DBT." Cuz traditional DBT, it's individual therapy groups, like there's a certain way that you do it. I find some of the skills in DBT and they've researched DBT, CBT, all those different things. And with dialectical behavior therapy, the skills are the most important part. And in any type of treatment, the most important thing is the relationship that you have with your therapist. Because if you don't feel safe, if you don't feel heard, if you don't have a good relationship with your therapist, like that truly is for client progress, that's one of the biggest indicators. And I just say that because I tried to push through. I didn't have a good connection with my first therapist, and I tried to push through it, and and really, I wish that I had stopped after that first session where I realized this isn't the right fit for me, and that I had looked and found somebody else at that time that was more appropriate. I did go back later, and did find someone that was really, like, a really good fit, and yes. And so, with dialectical behavior therapy developed by a psychologist, Dr. Marsha Linehan, she's later come out and disclosed that she has borderline personality disorder and that she created this program to help her manage her symptoms. That CBT and that these other treatments, behavioral therapy, psychoanalysis, those things weren't helpful for her, but looking at this hybrid of things, that this was something that worked for her. And how it relates to chronic pain is that you can work on reducing the distress associated with intense emotional and ongoing physical pain, and look at living with physical pain, and addressing the emotional toll of that and helping give the person tools like distraction. So I have a lot of clients that when their pain levels high, they get a lot of relief from engage, like maybe watching something, or they have certain games that they play, but that those distractions can often be really helpful when they are having a high pain day. Engaging in self-soothing activities. For a lot of my clients, naps are one of their favorite things, and it's giving themselves permission to do that, because sometimes it's like, oh, once again, I should be doing this or I should be doing that, and but in taking care of their body, that's going to help them have lower levels of pain and be able to do more. And then mindfulness, because sometimes with chronic pain, there can be this dreading the next bad day or the next high pain day. And so in the moment, what a mindfulness practice does is it helps me enjoy the now. So if today is a good day, being able to sit in that. And a good day for me is going to look different from a good day for somebody else. So for my chronic pain clients, we normally like to redo their scale, where if 5, so 1, because we talk about, like, the pain scale 1 to 10 or 0 to 10, and if 5 is the lowest amount of pain that they normally feel, we try to reset their pain scale, where 5 is their 0 or 1, so that can be a good day, so that they can enjoy technically their 5 out of 10 day, because that's the lower amount of pain that they typically experience. And so we sometimes recalibrate things, um, because um, especially if they have a chronic condition where the idea of no pain, that's not going to happen, that they are going to manage increased levels of pain, and where often they become desensitized to it at times. And sometimes there can be some trauma symptoms that can go along with that as well, some checking out, some dissociation. There can kind of be some different ways that people cope. When their symptoms are well managed, they typically don't have those issues, but when they have high, pain, that sometimes those types of symptoms can definitely pop up as well. Let me come back to the chat. Ah, yes. Um, and so I wonder if it's DBT self-help. Nissa, is it DBT self-help? I think the chat on YouTube, it might not let you put a um, it might not let you put it there. Yay, you like the idea of that recalibration. So I've had a lot of clients find that to be really, really helpful. And I should make this a little bigger. I've had a lot of people find that to be that to be helpful. Yes, love 20-minute naps. Yes. So, and then that DBT was effective for you. So I practice DBT skills. So that's why I talk about them so much. My brain is wired to not be in the moment. So I am naturally wired to kind of worry and to be a little anxious and to constantly be thinking about the next thing, which can ruin my present moment. And so actively practicing mindfulness is really helpful for me. Yes. Yay. I'm glad this is helpful. So that's always my goal, is to share things that can be helpful. There is a guy. So y'all can let me know. So it's Dr. Alan Gordon, and he has a book. I have his book at my work office, not at the home office, where he talks about um oh my gosh, being able to pain reprocessing. And his book is called The Way Out. And we will watch just a short demonstration of him doing, excuse me, doing the pain reprocessing. Share this tab. All right.
So you're feeling anxiety right now. So what is that like for you? Where are you feeling that?
Sort of feels like a lump in my throat.
And so what he's doing right now is he just kind of met with a person and went over their pain, and now he's talking through the emotions that they feel, especially around their pain. And because so our emotions, we feel them in our body. And I like to get a feeling from clients. Some people, especially individuals with autism, sometimes being able to feel like where things are in their body. Some people struggle with that. And also if people have things that have happened in childhood, sometimes there can be a disconnect with the body and actually feeling the sensations. And so he's trying to work through the sensations of anxiety.
Okay.
Feels a little bit like it's hard to breathe. I
Okay.
keep thinking about my breathing.
Okay. We're just going to do like an anxiety regulation technique. Okay.
Okay.
You don't need to do anything. You don't need to get rid of the anxiety. I just want us to get like a little practice helping you familiarize yourself with it. All right. So I want you to make yourself comfortable. You comfortable?
Yeah.
And I want you to see if you can just bring your attention to the physical sensation of the anxiety in your body right now. Okay. Breathe into it. And I want you to see if you can just describe it for me. Is it pleasant or is it unpleasant?
Unpleasant.
It's unpleasant, yeah. All right. Is it widespread or is it more in like one specific area?
It seems like it kind of goes across my shoulders.
Okay.
Too.
And it's a lump right there?
And a lump there.
So there's a lump right there and it goes across your shoulders. Mm-hmm. And how would you describe the sensation? Is it a tightness? Is it a clenching? Is it a fluttering? Is it a pulsing?
Sort of a pulsing, fluttering.
A pulsy kind of fluttery feeling right there. And is there a tightness? Because you said it was hard to breathe.
Yes.
Okay. So what I want you to do is I want to see if we can just help you pay attention to this physical sensation. You don't need to get rid of it. You don't need to make it move. All we're doing is we're trying to pay attention to the anxiety. Okay, we're not trying to get rid of it. There's no ulterior motive here. I want you to just close your eyes, and I want you to bring your attention to the physical sensation of the anxiety in your chest. And it's just this unpleasant sensation, and it's kind of in this one narrow point in your chest, and it spreads out to your shoulders. And all you need to do right now is just pay attention to it. All right, you talked about when you were a little kid and that you needed to be paid attention to, but you weren't. And I think that as a result, you learned to neglect yourself in a certain way because that's what you were taught. So you're feeling anxiety right here in the moment. And instead of attending to the anxiety, instead of taking care of yourself the way you needed to be taken care of as a kid, you were just trying to distract yourself from it. You were, focusing on what you were saying to me and me understanding you and how you were coming off, right? Right. So what you were doing is you were taking care of everyone else's needs, but not your own. So what I want you to do right now is just to take care of yourself. And by that, I just mean pay attention physically, physiologically to the sensation of anxiety. You don't need to do anything. You don't need to win. You don't need to be, charismatic. You don't need to be brilliant. All you need to do right now is take care of yourself and just pay attention to this physical sensation, okay? Okay. So I just want you to breathe into it and do nothing. There's no goal. There's no ulterior motive. You're just like a passenger in the car. You're just watching this thing. And my favorite analogy is like if you're like ever been snorkeling or scuba diving and you see like a really cool fish or something, you're not doing anything, you're not chasing after it, you're just watching it. You're just watching its patterns, you're just watching the way it swims. I want you to do the same thing. I just want you to watch it. And whatever happens is okay. If it subsides, if it intensifies, if it moves around, if it starts expanding, if it changes in consistency, it's all okay. All I want you to do is just sit with it and watch it and ride along and really just kind of watch this physical sensation of anxiety with almost a detached sense of curiosity and interest. I mean, it's kind of interesting that like.
All right. And so the goal of that type of intervention is to take the power away from the anxiety or power away from the pain, because sometimes fighting pain makes pain worse. So often if I'm physically hurt, the understandable thing is to clench up, and often the hardest thing to do in that moment, and it goes against everything that your body, your brain, everything is saying, because the more tense I am, the more I'm in that stress response and the more pain I'm typically going to feel. And so his type, it's called pain reprocessing therapy. It's a specific type of therapy. His book is called The Way Out. And because first with his goal, it is to figure out, is there, even if there is a physical reason for the pain, helping people to, I'll say it multiple times here, live well with the pain. And that often when we fight the pain, that it ends up getting bigger and bigger, which is understandable that a person would want to avoid it and not have it happen. That is the 100%, like that's the understandable part. But doing that often makes things worse. And so let's talk about spoon theory. And I saw in the chat that somebody else used it. And has anyone not heard of spoon theory? I heard about it on TikTok, of course. Like, where um, but it is an analogy that people use for chronic pain, where some days you'll wake up with no energy at all. And sometimes you see people have physical spoons where it's like, okay, brushing my teeth, that's one spoon. Uh, brushing my hair, that's another spoon. That on some days, I'm just every little thing is just going to take all the energy that I have, and there are going to be some days that I'm not going to be able to do it all. And it's a way to kind of the way I see it, it's a way to be gentle to yourself and to um on a high pain day to be able to logistically think, okay, I'm not getting the laundry done today. If I'm out of a certain thing, I might get it in the washer, I might get it in the dryer, but I'm not gonna put it away today. That being able to make little adjustments and things to life because smaller tasks like showering, getting dressed may only cost you 1 spoon, but then things like cooking, vacuuming, that those things will take 3 or 4 spoons, and that with increased pain levels, even smaller tasks could require more and more spoons. And the goal of it is for it to be a self-pacing strategy that emphasizes the need for people to work with what they have and to spread their energy across whatever they want to get done, and knowing that not everything is going to get done on a high pain day. So I hope that helps. Now, all right. I did want to share, and if you all have, so this is anyone's warning for the Maya Kowalski case. If you don't want to hear things on that, please go on ahead. If you need to drop off, that's not a problem. Or if you need to ask any questions before. Ah, nice. That's super cool that your son taught you about spoons. So I heard it. I heard about it over on the Clock app. But yeah. So let's share this tab. This was said today, a link between red hair and pain threshold. I had never heard of this. And I guess they did a study in mice and the mechanisms that may link red hair and greater pain tolerance, but then also that sometimes, and they think that there's some type of genetic reason that sometimes people with red hair may either require higher or sometimes lower doses of some types of pain medication. Like I had never heard that before. And of course, I went straight to the handy dandy Google. So when I do Google things, I try to find reputable sources, reputable things. Do you all have any questions about the testimony? Yes. Please let me know. Um, please make sure that you take care of yourself if you are watching the case. I have had a range of emotions. I've had to take breaks. So somebody asked me a question and wanted me to cover something. I want to say I was thinking about doing it last weekend, but there was a major something came up for me personally, and I didn't have it in me to talk about the case. And so being able to just take care of yourself as you're watching, bye, take care. I get it. Okay. So that's why I did my warning. So if you need to pop out, please do. Um, for the Maya case, as you watch, are you also getting frustrated by the general reaction towards Maya and Beata? And what I'm trying to do in watching, so the streams that I enjoy watching are Law and Lumber. I feel like Rob is doing phenomenal recaps of the legal aspects of this case. I try to talk about it from the psychological perspective. And I get why the defense is focusing on certain things. It'll be interesting to see if they're able to bring their Munchausen specialist in. But even if they did suspect Munchausen by proxy, that does not explain why they kept Maya in the hospital for that period of time before the court order was in place. I think it's 2 to 3 days. It does not cover, doesn't really explain that portion or the things that happened while she was in their care, like the fact that this weird stuff with Kathy Beatty, and I was really upset. Good gosh. The therapist from psychologist, the neuropsychologist from yesterday that did the psychotherapy, and while this person, I think, because I can't make statements about people's, like, I don't want to be I can't make statements about people's character. I personally, if a child had reported what Maya reported, and let me go on ahead and put my trigger warning thing up. I think it's this one. Yes. If someone had said what Maya said, I would have had more follow-up questions. If you don't know what I'm talking about, it came up that the neuropsychologist from yesterday, that she had in her note that Maya said that she had previously had a doctor come in and examine her. But then, but the neuropsychologist assumes that it was from the past. And even the judge was like, we don't know. And I think the plaintiffs were trying to, I think, they, because they could have, I think, asked for a mistrial, but like it, they would have had to start all over. Like the whole thing was just very, very complicated. And but if her testimony had got in, even Rob, everybody was saying that if the jury heard that there was even a potential that a doctor at John Hopkins did what he did, there would be a ton of zeros. There would be a ton of zeros going. I have a 6-year-old. We've talked about this. At his last wellness check, the doctor asked, "Okay, so who's allowed to look at your," and my kid was like, "Me." Like, "No, nobody, like, only me." And the doctor was like, "Well, and doctors and mommy and daddy's here, and like and so my like that was a very so I'm big on the body autonomy of children, and my kiddo could in the future talk about, like, it was kind of stressful, having, but like if somebody asked follow-up questions of, okay, so who all was in the room and where did this happen and when did this happen, that we would have, okay, mommy and daddy were there, we were there we talked to him after. I thought I had warned him before, but and but yes. um and what other testimony? They said that Dr. Sally Smith might be in 2 days, they said today. And I will see if I schedule a Saturday live. I'm speaking this Saturday. Oh, I'm out of it. I might have to do it on Sunday. I might have to go live on Sunday if the jury asks really good questions of Dr. Sally Smith. Yes, this case is so important to me because it shows a lack of empathy for anyone with chronic pain. Yes, yes. Um, and I lived in Germany, so from the as soon as this case came out and I heard the details, I felt that that it was partly cultural. And Beata might just have just been like a mama bear who makes sure to and I'm not saying mama bear in a bad way. I'm saying like there are people that just diligently like they are trying to get their kids the best care. They're trying to do those things. And anyone that doesn't understand that has never been in a situation where you or a loved one is having a disagreement with a doctor or a nurse. I had a situation one time where I was not in agreement with someone on the medical team, and I was very, very frustrated. But because I'm a psychologist, because like, I knew I didn't wanna get kicked out. So, if I had done and said the things I really wanted to do and say, it would have caused problems for my loved one. And, I had the foresight to know that, to think that. while I while I grew up here in America and then also overseas, I know enough about the culture in my area where I knew what was socially appropriate and what wasn't. I and I truly think Beata didn't think she was doing anything wrong. Do I work with children and teens? So I became a psychologist specifically to work with children and teens. The hardest thing I ever did was working in a residential treatment center. So I worked on the with the youngest kids between the ages of 5 to I think 8, maybe 9. I think they were, like, between 5 and maybe 8 or 9 in a residential treatment. So these are kids that were not in their home. They had to live on this behavioral health unit. They had significant emotional and behavioral concerns. Their charts were just full of all types of just different horrific things where the trainer said, "If you were ever upset with a kid's behavior, with a child's behavior on this unit, go and read their chart." Like, the charts were just it would just make you wanna cry. In that position, I didn't feel like I was helping, and so I lasted 6 months in that position, and then I switched to do home-based services to help kids not have to go to places like that. So, going with kids with severe, emotional or behavioral concerns, but they're still at home, and we tried to stabilize them within the home. I also, used to run a school-based counseling program that was funded by Medicaid, and I was in, my program was in 14, yes, of our area schools, and I would go around to the different schools to check in with the counselors, and, I had a pretty good idea what was going on with some of the cases, but, um, what I realized is that often when I'm working with kids, doing it as a family is really important, and if I was working with this family, I probably would do family therapy too if I could because helping the family cope. So as a mom, it's hard for me to see my kid in pain. And depending on my own history, depending on my own experience, it would be normal. So no parent wants their kid to be in pain. And there's a way to respond to a child's pain that can help. So I'll tell y'all a story. So my kiddo, I know I've told this story over on the clock app. I don't know if I've said it here, but I forget if my kid was like 6 months old, but he was a baby and he had this horrible cough and it sounded like a wheeze. And so we went to the doctor. We had a great pediatrician. We could schedule appointments as needed. And the doctor did the little oxen, the little, and this was before COVID. So did the little oximeter test. And this kiddo had 100% oxygen. And so the doctor was like, "Oh, he's created a little fake wheeze, like and it was like he had no other symptoms, he wasn't doing anything else, and he probably had a little cold, but that was probably it." And so she was like, "Just don't react. So when he makes that noise, just stay calm. Like don't go like just don't react if he makes that noise." With young children, they'll tell you so when kids fall, very, very young, I'm talking like at 2 years old, maybe 3 years old, they always look to the parent to say, "Am I okay?" Now, if the kid has a broken leg, it doesn't matter if that parent is like the most like when yeah, but if a kid falls, as a parent, I want to do my best to manage my emotions, and I say this as an education. This is in no way, because Maya's pain was chronic and it was so complex and it was like beyond and they had to do what they had to do. So I in no way like this isn't I'm just saying for other parents, if you have a child in pain, that the parent's reaction to it is very important because kids look to the parent for am I okay? And that's why when they said when mom was in the room that Maya reported more pain, but I think mom was her safe person in her safe place. So my kiddo had got injured at school and didn't tell anyone. gets in the car with dad and is like, "Oh," and he had like an open wound. And we're like, "You should have went and told the like you should have went to the nurse." And my kid's like he wasn't crying, like he wasn't, but he was injured. And so being able to but he didn't tell anyone at school because he wasn't comfortable to do that. But as soon as he got in the car with dad, he let him know that he was injured. And yes, so it's a whole thing. Hey, Phoenix, welcome, welcome. Thank you, thank you. I if I ever do start teaching again, I will definitely let y'all know. Some therapists follow me, so either some therapists in training or some licensed therapists. I miss being able to train mental health providers, and so being able to put this information out there because a lot of people don't understand pain and doing continuing education. So that's what, in order to maintain my license, every year I have to do a certain number of trainings. And so learning about different techniques that help incorporate body and brain and just the emotions, I think those types of techniques can be really, really helpful. And so um I agree that the saying to not freak out is easier said than done. And what I do is I fake it because the normal reaction is going to be the oh my gosh, like this is, and that's the normal reaction. I try to do my best to breathe. Oh, Nissa, congrats. Good luck. I hope that process. So normally when you submit your paperwork, like as long as everything's okay, hopefully you get that approval back soon. If you ever have questions about starting a practice or if you ever have different questions, feel free to leave them in the chat. And then I try to schedule sessions and meetings. There are things that I wish I knew that earlier in my career that it took a little bit longer to find out. But um, you always believe the child. Yes, I agree with this. And you just do. And often in cases of actual Munchausen, the parent doesn't want the child to get better. Like they don't. And that's why to me it was clear. So the parent and family, those months that Maya was doing better, like everybody was happy, things were fine. Like you don't see that in actual Munchausen's cases, that in cases where that parent does need to get their own attention through the child, they are going to continue to escalate. And so yes, Phoenix, just rewind back maybe 20 minutes or so. But yep, I already covered that, or make sure to catch it on replay. I'm gonna try to add timestamps probably by tomorrow, but maybe tonight. We'll see. But I'll try to add timestamps. Any other questions about the Maya case as y'all are watching? I'm probably going to head over Recovery Addict. That's the stream that I've been watching. I actually have it playing in the background. I have it paused, but I actually have, because I'm going to catch up, because there's a medical doctor. I don't know if they're an anesthesiologist, but their specialty is in yes, is in CRPS, and it is a bit. The jury, I think, has asked that individual more questions than anyone else. If y'all don't have any other questions, I'm so glad to get to just provide this education. If y'all have questions or other videos that y'all want for me to cover, please let me know. But I hope y'all enjoy the rest of your day. Bye.